Hi guys, small minor changes and problems because I'm doing it for the first time. Am I audible? Hi Manisha ma'am, thank you so much for joining. Hi Chandan,
Hi.
hi Dr. Chandan.
Hello.
Hi, people are still joining in, so I think
Okay.
we'll start our session first. So
Yeah.
first, I would like to introduce myself, and I like you to do the same.
Sure.
I'm a second year resident doctor at Savita Dental College in the Department of Oro and Maxillofacial Surgery. Please give your introduction, sir, if you could.
Hi, I'm Dr. Chandan. I'm a consultant neurosurgeon. I'm currently practicing at Miyot International Chennai. It's good to be here and collaborate on this video. I think today we're going to talk on a very common topic that's affecting all of us, facial-maxillary trauma and head injuries. So I think should be a good session ahead.
Yeah, I'm also looking forward to it, sir. One more thing, before starting the session, is that we would like to discuss more about the aspects where people who go under road traffic accidents, they really do not have an idea about which intervention is required in the first prior procedures, such as a neurosurgical intervention or a maxillofacial interventions. So the situation-based scenarios we like to discuss, where we both would like to share cases which we have encountered, and we give a suggestion on how we can tell the patients and educate the patients on which intervention they would require earlier, so that they can save more lives, and more importantly, more post-op complications can be prevented in those scenarios.
Yeah.
So, yes, sir. So, I would like you to give a scenario on your basis, and I would start with the scenario as such. If there's any presentation you would like to share, it'd be helpful.
Yeah, sure. So the most common thing that I, as a neurosurgeon, see, I think, is trauma. So most likely, patients will have had a road traffic accident somewhere far away, and they'll be brought to us about 3 or 4 hours later. So that's the most common thing that we see, I think, and that's also where I think there's a good collaboration between the maxillofacial surgeons and us, because head trauma is usually associated with face trauma, and with the rising awareness of helmets and other things, I think blunt face trauma is more common now as compared to sharp objects.
Hmm.
So earlier, I think about 15 years back, it was more of sharp objects that were pricking in and causing problems. But I think now the trend has changed. So I think so. Usually we have these patients coming in anywhere between 3 to 4 hours, but I think within 6 hours is a golden period for us to do any kind of an intervention. So this is what we're looking into to see, to have the lesser time between the time when the patient starts and the time when we get to see the patient. So when they come to us, usually they are assessed in the ER. So the ER physicians first see the patient, and they will be coming in with accident. They'll have other areas of fracture. So the ER physician first does something called an ABC. So they look for the airway, they look for the breathing, they look for the circulation, and then after all of this is established is when they check if they have any injuries extra over here, then they will do a basic suturing, and I think after that they will involve us. So as soon as the neurosurgeon sees the patient, the first thing we'd want to look for is a scoring system called the Glasgow Coma Scale, or the GCSF it's called. So in that we have a total of 15 points. So we see how the patient is, whether we ask them what their name is, are they keeping their eyes open, and it's a large case. I don't want to get into the technicalities of it, but this is the basic thing. So if your score is anything above 10, then it means that the chances of surgical intervention immediately is less. So we need to look in, we see that. And if the surgery chances are less, then we do a secondary survey. and so on and so forth. And once that is done, then we involve the other specialists. So we give a referral to a maxillofacial surgeon, we give a referral to an orthopedician, we give a referral to a plastic surgeon. So all of these people get involved, and then we holistically treat the patient. So I think
Yes, sir.
this is the most common scenario that you see. So you can share with us what you see commonly and where you get involved at this stage. What do you see? Then we'll go into how we assess the patient and other things.
True, sir. Like in a country such as India, we have so many common road traffic accidents happening every day that it's very inevitable for people to survive at such a rate if they have not gotten primary intervention at the earliest. So, according to us, when we have a patients who require any surgical intervention, we always refer it to a neurosurgeon if we have a clearance from neurosurgery side. For an example, the head and neck traumas, may the most common traumas that we go across would be if the patient is stable enough, having a GCA stable enough, we'd always operate him under supervision of whatever trauma further that he's having. There are multiple traumas that we have, comminuted fracture traumas. I would like to discuss one case which I was reading about. It is from a textbook that I had been reading. I'd like to discuss this
Mhm.
case and share the slides with it.
Mhm.
Apparently, I think it's unable. I'm unable to share the slides, but
You
there
can
was
just
a.
share the photos. That would also be okay.
Uh, okay, I would like to share the photos, but apparently, I'm unable to do that. Yeah, so apparently I'm unable to share the photos, but there was a road traffic accident which happened. Patient had a history of falling from the height, and
Mhm.
patient had a history of falling from the height. When he fell down from the height, he had malocclusion in both of his jaws. There was a primary intervention which was done for the patient. After doing the primary intervention for the patient was referred from the neurosurgical after the neurosurgical clearance to us, and the patient had undergone primary treatment over there for a fracture of the condyle and fracture which was not treated as such, and
Mhm.
the fracture of the angle which was treated using a recon plate, and then it's a rigid type of fixation that we usually go around. And then once the patient still came up with a review period of 10 weeks or something, having a malocclusion and a mobile segment into it.
Mhm.
Once we intervened, we realized that the patient had undergone a case of malunion and the patient's segments had not united properly. In those malunion segments, those fractures which were not able to be united, we tried to open it up and we tried to give a better recon plate and fix the fracture segments together. All I mean to say is whenever we see patients who are keep continuously falling down also, like for an example, patients who have fallen down or guardments, for example, they have been standing for a long durations of time and they fall down, they not only have fractures in one segment, they have fractures which are an impacted source of fractures. For an example, a fracture to the angle of the mandible or to the symphysis region of the mandible with that of the condyle. And a lot of times the condyle can actually invade into the middle cranial fossa, which doesn't happen because the squamous part of the temporal bone is extremely strong enough. All I mean to say is whenever we have fractures which are impacted fractures, fractures which have had indirect hit, it is very easy for us, for anyone to miss those kind of fractures and not give a proper surgical intervention. And those
Mhm.
fractures are also the fractures which would always have a EDH component or an SDH component to it.
Mhm.
So I would
Yeah.
like you to elaborate on those fractures or a gunshot wound injury fractures or a blow to the fracture face of the fractures.
So gunshot wounds are quite less common here, at least where we are in Chennai. But we have seen a few cases. So it depends on the type of gun being used also. So if it is a shotgun, then there is a pellet distribution. So so shotguns, how they're fired is this is the bullet. It goes and it splits. So each of these pellets
Yeah.
can penetrate into each different part of the skull or face or whichever
Mm,
part we're dealing with. So depending on the force of the fire,
mm,
the pellets go to a different distances. As you
mm,
said, the weakest bone or the thinnest bone is right here.
mm,
It's called the temporal region. So in those areas, even very light force
mm,
trauma can penetrate and go in. So in those cases, it can get dislodged inside, and that entire area where it's
mm.
going in like this, it will leave a trail of blood wherever it goes. So depending on which area is getting affected, over there you lose more blood or less blood, and So when we do a CT scan, like I said, after you do the primary survey, we do a CT of the brain. CT of the brain will pretty much reveal anything that is related to trauma. You can call it the gold standard of trauma investigations. So that's what changed the face of surgery or trauma care in India in the last 20 years. So in more than anything else, I would say it's the CT scan, because when you had X-rays, you had limited information. So once you do that, you'll get a clear picture of where the bleeding is, how much bleeding is there, and which area of the skull is having it. So once the bleeding is quite less, say the patient is completely conscious, oriented, he's able to talk, he's able to tell his name, and if you shine light into the eye, it's called a pupil. So if you shine light over there, the pupil will constrict. If that is happening, then there's no issue at all. We can wait and we can even intervene after the next day or the day after that. And if they're completely normal, there's no blood in the brain as such, then we give it over to the maxillofacial surgeons and you can take over and you can do your case. But if the bleeding is there, then we look into it, we do the CT scan, and if it's showing an issue, we either do surgery or we leave it like that, we observe for 3 or 4 days, and later we go in for a surgery. So this is how we would like to manage it as soon as we see the
So
patient, at
according
least.
to you, sir, if a patient is coming to emergency and if the patient is having a subdural hematoma or an extradural hematoma, very visible and evident onto a CT report, what would be the time duration after which you can give us an intervention where we can interfere and we can involve our treatment from our side? For example, if a patient is having a bicondylar fracture or a fracture of a counter coup mechanism where there is an indirect hit or indirect injury to the mandible, and most of these times, these are the fractures where the patient is very enthusiastic about evolving and generating a treatment for any neurosurgical intervention. But a lot of times, the patient takes a time duration of at least 10 to 12 days after the trauma which has happened. And when he comes back after that period of time, there is already a chances of non-union that has happened. So there is already a chances of bone aberrations and all those deformities, which even if we try to fix with a rigid sensor fixation, would not give us a kind of a result which we're expecting it to be. There would definitely always be the exposure, or there would always be a site of infection. So I just wanted to ask you this because a lot of times, a lot of patients, after even not having a neurosurgical interventions, they do not appear up back to us. They do not appear back to us, and that leads to a lot of chances of malunion and non-union in those trauma segments, which we, even if we try to remove or if we try to bring those segments back together, we cannot do that as such. Because for us, sir, as oromaxillofacial surgeons, out of all the 14 bones that are required or that are there in the craniomaxillofacial structures, mandible is one of the most common and most easily mobile bone. And the condyles of the mandible and specifically the angle region, because of the cortices and the intersections of it, it's the weakest portions of all. We have seen a lot of case scenarios where even after the interventions of neurosurgery and after we have been handed over the case, the patient does not show up because there is no awareness towards patients as such as to why immediate intervention is required in the region of the oromaxillofacial region, because they appear after a month or they even appear after 3 months, stating the fact when they're unable to chew their food, sir. I mean to say, whenever they have interventions, only when they have so much pain in the site of malocclusion or say site of eating, then they come up to us. So I would like to clear from your side as what all time period is a mandate time period and an acceptable time period for us to not intervene if there is a neurosurgical intervention, and also when is the time period for us to intervene if there is no neurosurgical intervention.
Okay. So what you said happens very commonly. So this is actually one of the most common referrals we get as a neurosurgeon in any tertiary care hospital. So we get most commonly maxillofacial surgeons keep asking us, can we intervene today, sir? Can we intervene today, sir? But the thing that we look for is, at the end of the day, we want the patient to be having a good quality of life. So, like I said, if the patient is having a large hematoma, let's say you've seen the patient, the scan is showing a large EDH, so which is an extradural hematoma. So, what is an extradural hematoma is that the blood is there between the skull and the dura. So, dura is one of the coverings of the brain. So, this particular EDH is a very problematic entity because we need to intervene quickly. If the EDH is large and it's causing a shift of the brain, then we need to go in for a surgery very quickly. There is something called a time frame interval in which we have to intervene. So if that happens, then we need to go immediately, open the skull, clean out the blood clots, and then fix the skull back. So once we do that, the next day we'll take a CT scan. Now, if the CT scan is not showing any extra blood and if the patient is all right, then after that, up to 72 hours, we will wait. So 72 hours is a golden period. So minimum above 72 hours, we'll be keeping the patient under us. We'll not be able to give it over to you for intervention. So after that, if the patient is doing well, he's able to eat and he's able to talk normally, he's able to obey commands well, then we give the patient over to you to go ahead and fix it. For SDH, the situation is very complex because SDH, what is an SDH? So SDH is called a subdural hematoma. That means, so this is the brain, let's say. So over the brain, there are three coverings. These are called the meninges. So in that you have the pia, which is the most innermost brain. It's all innermost covering. It's almost opposed to the brain. Then you have the arachnoid, and then you have the dura. So in this dura, so subdural means that it is inside the dura but above the brain. So in this area, if there is a bleeding, it's in direct contact with the brain. So those kind of bleeds will irritate the brain for much longer. So when it is an SDH, we will keep the patient under us for at least a week or sometimes even 5 or 6 days. And if we do surgery, it's even longer. If we're going to do surgery for an SDH, then we expect that sometimes some of the patients, if I could show you a few scans, I could, but I don't think I'm able to share the images. But we've had patients who've been under us for an entire 1 month. And then after that, they've gotten better. And after that, we've given them over to the maxillofacial surgeon or to the orthopedician to fix their bones. So this is the criteria for us. For us, the criteria is that the patient's GCS should improve and his bleed in the brain should be evacuated. He should be stable to withstand anesthesia, to withstand any kind of procedure. So once they're ready and they're like that, then we give the patient over to other physicians to go ahead and do what they want to do.
Okay. So first of all, sir, I would like to discuss a case scenario as to how the treatment that we do changes according to the time duration the patient actually reports back to us. So I would like to show one scan. It would not be clearly visible, but this is a scan where we have used into a patient which initially came to us after having a non-union, which you would say because there was no bone segment only after he came. Yes. And he would kept on a recon plate, which is a kind of a rigid type of fixation in which we take we actually bear the entire plate bears the entire load. It is not shared by the mandible because the structure that we are trying to fix is extremely weak for it to be shared. When the patient came to us, we had opened the recon plate and tried to remove the recon plate because the already man-union or the non-union had happened with that scenario. And this happened because the duration the patient had come upon, the non-union was there. It was more than 10 weeks and the segment entirely was mobile. I mean to say is the patient would have come earlier, and if we would have removed the malunion, we would not have to change the treatment plan, which had to happen. So what treatment plan then we went into is we had to put bone graft for this kind of patients. I would like to also start with discussing the surgical intervention as a surgeon which we go across if the malunion or non-union happens. For an example, in those case scenarios which you discussed about, if after giving the clearance from the neurosurgical point of sight and still the patient doesn't show up, and when he shows up, either there is a malunion or a non-union because the rigid fixation has not worked properly, or either the patient was the patient compliance was not that good enough, which caused to a lot of infection, which apparently is both of the reasons. And a lot of times, those fracture segments which have come across, we have to remove those fracture segments and put bone grafts into it. Now, when we talk about those bone grafting mechanism, which again is another type of a surgery which is difficult for the patient scenarios, we take anterior iliac crest grafts and either a free flap grafts for that patient. So the case scenario that I showed you, in which there was a recon plate and there was a gap of at least a proper gap from 1 to 6 of millimeters that had to be removed, we kind of removed that gap and then fixed it with a iliac crest graft. And after that, we put a recon plate according to it. The patient could have gone to a very easy surgery if only he would have come before the time period or time duration or stipulated time duration of malunion or non-union, which would have happened. But then again, because the patient was so today compliance is not that good enough in a patient of road traffic accidents. So he came after a period of duration of maybe around 10 weeks or maybe more than that, and due to which the treatment changed entirely for us as a surgeon.
Hmm. Right.
This is very evident in a lot of rural parts of India, in which people do not have a proper intervention and they do not go across multiple set of doctors. And a lot of times, people do not actually bother about treating the malocclusions of the face
Right.
and treating the fractures of the face per se, because they think
Mm.
that it is not a life-threatening situations. Until unless it's bleeding for them, until unless there's extreme amount of bleed or extreme amount of pain, in which they have high amount of chances of not able to move this entire segment, they will not come across to us, which becomes very evident in countries like India. So,
I
what do you
think
want to say
those
about
are the
those things?
times when I think you need to raise awareness.
Mm,
I think, and everybody in the team has to be involved and has to know the importance of doing something like this so that you can counsel the patient as a team. So I think what often happens is there is a miscommunication amongst the doctor community itself, wherein like you won't know the importance of what I'm doing, or I won't know the importance of what you're doing. I
mm,
mean, on a broader scale.
mm,
So I think if we all collaborate better, I think we'll be able to explain first to the patient, and also, of course, the question of awareness within the community is a big deal. So we need to make sure that everybody is aware of what we're doing, aware of the consequences of this. I think only when we do that we can change things like this, wherein the patient doesn't by themselves stay
mm,
longer for intervention or to come to us. They
mm.
don't take longer. So
So,
that I
one
think
more.
is a very
Yes, sir. Yes, sir.
important thing that we need to look into.
Yeah, so one more case scenario I thought I wanted to discuss, which was a very important thing, was it's a very common fracture that we come across, and it's parasymphysis body fracture of the mandible. So
Hmm.
when I was posted in my first ER duty, so there was this patient of mine who had a bilateral parasymphysis fracture, and the patient was in ICU because it was a very aged patient and an old patient who was undergoing that treatment for that parasymphysis fracture. We had started to plan an intervention. The patient was not cooperative enough for us to undergo any surgical intervention. And all of a sudden, we had to run code blue for that patient because the patient was unable to breathe and unable to, there was hello. Yeah, they was unable to breathe, and the patient had to be intervened immediately and had to undergo CPR. This thing happened because a lot of times, this patient having bilateral parasymphysis fractures, they have no support from the tongue, and the tongue tends to fall back quite easily and quite frequently. In those scenarios and case scenarios, in this bilateral fractures, if there is no proper immediate intervention given to a patient, there are chances of patients obstructing its own airway and choking in, causing to fatal chances of accidents. A
Right.
lot of scenarios, yes, sir, and a lot of scenarios which have come across is patient who have had a history of fall maybe 12 years back, maybe 13 years back, and he had undergone neurosurgical intervention, and he would have had undergone a mild, maybe conservative treatment from your point of sight, and the patient doesn't come up to us. Patient is being told about the consequences, but patient doesn't come up to us because at that point of time he feels everything is fine and it's all right, and there is no need for any surgical intervention because they're very scared of surgeries on the face. They seem to have that scenario that it always be extraoral scars which would be given, and the scars will be very conspicuous and it would be visible upon them. So in those scenarios, just to avoid those small amount of scarrings in this, they prevent themselves from going into any further interventions. And that same patient comes back to us, sir, with a span of maybe 5 or 6 years or 7 years, and patient has no mouth opening. He has been unable to eat, he has been unable to drink, he has been unable to speak also because his entire temporomandibular joint has undergone ankylosis. So those
Hmm.
kind of accidents which happen and could have been saved if he would have gotten a proper surgical intervention at that point of time where he would have gotten operated for the neurosurgical also. But then he has a TMJ problem, and then after that there is a very massive surgery undergoing where he has to either remove his temporomandibular joint, or either that ankylotic mass, that has that chunk of mass that he has undergone, it has to be resected, and entire jaw has to be resected, which again will never ever be the same way the patient will be when he could have gotten an intervention earlier. And
Right.
a lot of times, sir, even if there's no neurosurgical interventions in patients who have very poor oral hygiene or oral sepsis, because of the trauma, because of the underlying, maybe the primary closure in such a way that it leads to infection. and the patient is not bothered about those infectious site until and unless either there's a pus discharge from that site, or either there's a sinus tract that is formed again, causing to maybe space infections or leading to more dangerous chances of submacetic and pterygoid space infections. The patient is unable to, and there's a huge swelling on the face. That is the only time the patient intervenes. And when that space infection patient comes to us and we take a radiograph or we take a CBCT or a basic orthobandograph, we see that there's already a fracture which was not addressed, and there's already a manual which has happened in the case scenarios. So, according
Yeah.
to yes, sir. So, according to you, sir, what all interventions as a oromaxillofacial surgeon should be taken from our side so that we can manage both of them simultaneously and also give a better and proper care to patients?
I think what you need to decide on is the timing of the surgery. I
Yeah.
think that's where I think it makes a difference. So the issue, except for fractures that involve the base of the skull,
Mm.
specifically this area,
Mm.
so those areas we wouldn't want you to intervene immediately, because those areas
Yeah, correct.
we will have
And
CSF
Leaford
leak.
fractures.
So
Yes.
we'll have Leaford fractures where you have CSF leak. I think Leaford 3 and 4 and
Mm.
above, where you'll have a lot of leaking of the brain fluid inside. So what happens is, anything you do here, if
Mm.
at all even one microbe from the nose, or this area is a dirty area,
Mm.
any one small, even 1 to 2 ml is pushed into the brain, the patient will develop something called meningitis. So
Mm.
meningitis is a very scary problem because it is inflammation of the outer coverings of the brain,
Diametricious.
like I said. So because of that, not only will the patient have a problem in the brain, they will have a problem in the spinal column also, because the same CSF flows through the spinal cord.
Mm.
So once all of it gets infected, then we are dealing with a very big problem. The patient can go into something called sepsis. So
Mm.
that, and potentially it becomes a life altering problem. The patient may even lose their life sometimes, even if we give them the right antibiotics. So apart from that condition, any other conditions that are there, if you want to do any external fixations, once we are done with the surgery and the patient is hemodynamically stable. So what I mean by hemodynamics is the blood pressure, the pulse rate of the patient's general condition, the blood
Mm.
loss, all of these things, once they are stable, I think you can intervene. Usually it's about 1 or 2 days, like you said. But there are rare cases of very large hits where, despite us operating on the patient will not be stable for about 1 week, 10
Mm.
days. They'll be kept in the critical care ICUs. And those patients, unfortunately, you will not be able to intervene quickly. So, those cases, I think we will have to live with whatever is the best possible result you
Mm.
can produce given the current circumstances. So, that I think is a little bit of a gray area. But I think all other cases, as early as possible, I think going in for an intervention is better. And from our side, we do give it off rather quickly. Once we're done doing the surgery, then the patient is stable, we can pass it on to you. Yeah.
And so, what about the case scenarios? How the patient is adamant on getting an intervention from the oromaxillofacial surgery side because it's not bothersome to
Right. I
them over a
think
point of
that's
time.
when we need to counsel to them the importance of doing something like that. Maybe even show them a few photos.
Mm. I'm sorry, sir, you're not
How
audible.
bad it can be
Mm.
otherwise, and what to do, all of those things. I think that's very important that we do a team counseling.
Mm.
So when we are speaking to the patient, we would ideally want to have a neurosurgeon and maxillofacial surgeon, a trauma surgeon, and all of us, I think, should talk together to the patient so that they know the importance of it. So if you, and what response most of the people in India anyway, they respond well to visualization. So if you
Mm.
show them actual photographs of people who haven't done it on time and what it's done to their face, only then I think people will understand what the importance of something like this is. So that is what we do. Like I have a lot of cases of people who have refused surgery and who've just stayed like that, and they've even lost their lives. So whenever we show such patients, of course with consent, we have to, whenever you're showing anything related to any patient, we
Mm.
take their consent. So with their consent, we share it with other patients so they understand. There are patient to patient support groups which help with all of this. So there is a head injury support group which we run in our hospital, where all the head injury patients are added into that same pool. So we recently had one patient who came in. The wife had brought the husband, and they had just gotten married 15 days ago. They got into a road traffic accident. Unfortunately, his Glasgow coma scale on coming in. He was almost completely unconscious. He was barely able to open his eyes, barely able to move his hands. And we did surgery, and he improved. Within 10 days, he was able to get up, he was able to tell his name. He got discharged, he went into rehabilitation, and he came back to us about a month later, and he came into the clinic walking. So that such a patient is a big plus for all other patients. So when we create a support group like this and we add other prospective patients to these, then they will among themselves get an idea of, because whatever it is, at the end of the day, it's the patient and their relatives who are suffering. So they know it firsthand. As a doctor, we can only tell so much. So once they get firsthand information, they're more, pushed into or more convinced to undergo these procedures. Because at the end of the day, surgery is scary for everybody. So I think that will work. I think that's something which is being done now at a lot of corporate hospitals, but I think it should be done more on a larger scale.
And then what about the chances of assault injuries, which is very common
Assault
here?
injuries are very common.
Yes,
So they assault
which
injuries.
cause, yeah.
Yeah, go on.
No, sir, assault injuries are those kind of injuries where even after doing a proper surgical intervention, maybe you would have had undergone interventions, maybe a neurosurgical intervention is required, and by even that point of chance, the patient is not able to be in a proper state he was. And there is always assault that has happened. And then also the patient's relatives are not that compliant towards the treatment. They always think that it's always the surgeon's fault to be not able to get a proper result, which apparently is not true, because a lot of time even assault injuries are so damaging and so severe that they come after a surgical intervention from other care centers which have already denied them a proper care. They have undergone only primary closure. I had a case scenario with this where the patient had undergone only primary closure, that is just the suturing in this. And when we reopened it up, it was a pan facial fracture. It entire fracture was there, and they were very adamant of even getting a fracture treated per se, because they did not wanted a hardware or a plate inside their face. And it was very difficult for us to intervene and explain to those kind of situations in patients where that patient having a pan facial fracture, because he was not having any sense of blood loss. It was just that he was having mobile segments in this. So he just wanted an intervention that was conservative. And apparently in those scenarios, we cannot provide a conservative management as such. So in those scenarios, what do you like to talk about those assault cases where it's just the healthcare system somewhere is inclined towards not, because the patients are very apprehensive in getting a treatment as such.
So in assault cases, I think the problem starts even before they reach the hospital. So in assault cases, basically you're being hit. So there's a huge psychological component involved. So a lot of those cases, sometimes if it's very illegal and all of those kind of things, they don't even end up in the hospital. And if they're brought in a very bad shape. And also so first thing that you do in any head injury, whether be it an assault or be it an accident or be it a trauma or be it a fall from a height, also these days we do something called an MLC, which is a medical legal complaint which is lodged to the police. The police is given the information, and whenever the police is involved, there's always some degree of fear involved about it for everybody. So, but I don't think people should be afraid, because this is a system which is followed universally across the world. It's done so that fair treatment is given to everybody. Both the patient, the person who's getting assaulted is given a fair treatment. The people who are accused, who are doing the crime, they're given a fair treatment. So all of this is the basic justice system. So once that stigma is solved, then I think patients will come to us quicker. So now when they come to us, assault, usually the problem is the pattern is very complicated, because injury may be in multiple disconnected regions. For example, you can have assault, a person can stab on both sides of the head. So you can't go ahead and do surgery on both sides. Sometimes it's necessary, but most of the times we don't do that because the injury is very severe. So in those cases, we need to again look into the scan. We need to assess the patient clinically. We need to see how the patient is talking, how the patient is walking, what are his vitals, how is his BP, how is his pulse rate, how are his pupils. So that has to be our guiding force, no matter how the patient came to us. So how the patient comes to us, mechanism of injury, it's only the other way that it matters. For us, it is SDH, it is EDH, it is leaf foot, it is mandible fracture. I think we just need to treat that part alone and leave this to the other people who are dealing with this in the system. I think that's where counseling of the patient comes into the factor, and I think that's where the ER physicians also need to play a major role. They need to encourage them more towards active treatment. I think that's very important.
And so in assault cases, I would like to add there are a lot of chances of missed fractures. Missed fractures per se, because assault, sometimes the patient was so unconscious or maybe under the influence of alcohol that he doesn't remember who hit him, what hit him, and a lot of times he's just brought into the ER with just bleed everywhere. Even after doing the fast scanning and everything, a lot of times patients are uncooperative even to take a CT scan per se, so they're always shaking, and when we take a CT scan in this, there is a maybe undisplaced fracture or a maybe a comminuted fracture which is very evident on one side of the fracture bone, but the other side which is also an undisplaced fracture. And then because it's sometimes very missed diagnosed or mistreated as such, because in assault cases there are higher chances of having multiple sites of fracture per se when we talk about, as compared to one single site. And even the same goes for the gunshot wounds also. Gunshot wounds also, if you talk about cases where there is already a conflict happening and there's a gunshot wound, there are very higher chances that it would always be a comminuted or compound fractures, the fractures which are kind of exposed to the oral environment and are comminuted. And even if we recreate those kind of fracture segments, there are higher chances of them getting involved and undergoing infections per se. Because the comminuted fracture breaks the fracture bone into multiple, it's like it's like everywhere the fracture segments are there. So these kind of scenarios, once we take a case history of the patient, we get to know what kind of fracture we can anticipate. And there are also chances of those patients who are not having compliance, because assault can happen again and again. It's already also sometimes the patient compliance is very little in comparison of assault.
Yeah, so in assault, I think so. What you should do is, I think nowadays fast scan is just a preemptive investigation. So fast scan doesn't give you a full picture. So you should go in for a CT scan. So and like you said, like if the patient is moving fast and those kind of cases, we'll have to sedate the patient and take the CT scan. We don't have any other option. Start the patient on a sedative drip, keep him under, and then do the scan. Then you should do a complete assessment. So this is where us clinically assessing the patient is very important. If you have a patient who's subconscious, be it under the influence of alcohol, be it the hit or the injury per se, or be it just that he doesn't want to talk, whatever it may be, in our standard protocol, we need to do a CT scan. So if the patient is moving during the CT scan, give sedation to him and then do the CT scan. This is sedation is a drug which we give to make the patient sleepy. So basically, anybody who's coming in this disoriented, fighting kind of a phase, we need to give them a medicine so they calm down. So once that medicine is given, they calm down, they're more cooperative. We put them into a scanner, we see the scan. If the scan is showing what we see as a surgical intervention related, then we go in for surgery. We take the patient to the surgery theater immediately. Sometimes we've had these kind of things happening at 2 a.m., 3 a.m. in the night, where even the people who are doing the thing, the healthcare system, healthcare workers are also tired. But even then, when we have standard protocols like this, I think we need to just stick to those standard protocols, do the scan, see the scan, evaluate it objectively, and go ahead and do whatever intervention is necessary. So
Okay.
I
So,
think
so
I think that's
what about the pediatric fractures, if you talk about, or pediatric interventions when you come across? Because all we talk about, there's a different set of protocols that are different in patients we are taking as who are pediatrics, or patients who are maybe not that equipped of taking any other fracture scenario. So what do you do when you have a patient who requires a neurosurgical intervention and also a maxillofacial surgical intervention, and a pediatric patient in situations like that? What do
so in
you suggest?
pediatric patient, I think the biggest challenge is managing the parents actually.
Yeah.
So because the parents are apprehensive because it's being a child, the child can't speak.
Mm.
So and the next question they ask is what will happen to the child in the future, the next 20 years to the child, what happens to them, all of these. So yes, it is. We completely empathize that it's a child and you need to look into what the child is going to be doing for the rest of their life. Agreed, all of that. But I think what we need to see is when we're treating children is that their bones are very friable. So compared to an adult bone,
Yeah.
the child's bone is much softer. And if it's a child less than 1 or 2 years of age, then there is remodeling of the skull happening. So you have something called fontanelles, which are open areas of the brain. So because of that, the skull isn't completely fused. So when we are treating such patients, we try to make it conservative treatment as far as possible, because the child's capacity for regeneration is much higher. So unless it's a very large bleed, if it is an adult, we might have intervened. Say that there was 50 ml of SDH in the in a child versus an adult. 50 ml of SDH in a child is far better tolerated versus an adult. So we try to make it go into a conservative treatment, but if it doesn't work and we have to do surgery, that is when we do surgery. So the big challenge when we're doing surgery is answering the attenders. So that part, I think we need to sit clearly with them. We need to also empathize, because at the end of the day, the child is the most important person for the parent. So we need to calmly talk to them, tell them what the result is going to be, show them the scans, show them what's going to be happening next. But the one thing that we should explain to them is a child will tolerate a more drastic surgery as compared to an adult. So that's a big plus point. When we are younger, our recovery and our rates of healing is far higher. So I think that we need to make them understand first. So once we tell them that, they calm down a little bit. Then you explain exactly what procedure you're going to do and all of those things. So you don't have green stick fractures in the skull and all. So only green stick fractures are for long bones only.
Yeah, correct.
So for us, it doesn't really matter. For us, we can just treat it just like how you would treat an adult, but take into factor the fact that the child will heal much faster than an adult. So only when it is absolutely necessary, go ahead and intervene. So that would be what I do most commonly with my patients. So I think that's also the standard protocol these days.
Yeah, so for us, no, as when we come to maxillofacial region of a child as compared to an adult, the entire treatment kind of situation changes for us.
Mhm.
In those situations, if we have a pediatric patient per se, we would not try to give or maybe open up the do a open reduction in internal fixation for those kind of patients.
Mhm.
If the patient is already in a where there is no proper what you say malocclusion or non-union of the segment has not happened, and the occlusion can be achieved, or it's just like a display undisplaced fracture, we would always go and intervene with a very conservative approach as such. Maybe put the patient on intermycin fixation or plastics like elastics for the patients. But even, sir, if we, like there's a certain protocol we follow as the titanium system we both follow for the plating. Like the titanium system is usually not followed in those pediatric patients per se. This is already followed if until unless the segments are way too displaced for us. If the segments are not too displaced, we would always like to do a conservative management for them. Maybe put a circummandibular wiring and then give them a cap splint. This kind of splinting which fixes it and then provides them the amount of malocclusion that is also required. And nowadays, so there's a use of resorbable plates. So these plates are made up of polylactic and polygalactic acids and all. These plates, they themselves resorb by itself. So you do not require a second surgery for removing these kind of plates in pediatric patients. We prefer those kind of plates in pediatric patients per se because we do not give them a second surgery again to maybe remove the hardware for them. And these plates are very stable, but as compared to titanium, if in case we have to give titanium, we always try to plate it in such a way that whatever tooth germs that are there in the pediatric patient, because the teeth have not grown completely, and the teeth should not become vital acid that it interferes with the dentition and the smile of the patient in the later ages. So those scenarios, we always try to remove the titanium hardware, maybe after a span of 6 months to 12 months, or maybe a 1 year, we remove the titanium hardware for them. So for those pediatric patients, the treatment is never aggressive as such as compared to maybe adult patient who has undergone a panfacial fracture, which requires an immediate intervention. And like you said, sir, even in those scenarios in a pediatric patient, the amount of capacity that they have for bone healing is far better as compared to adult scenarios. Uh, so, what do you think, sir, about the patients, like geriatric patients, if you're talking about the adult and this? So, what do you like to talk about the geriatric patients as such?
So geriatric, I think we should keep a cutoff somewhere. There's no strict number. It depends on the surgery also. But I think around 70 to 75 is a fairly reasonable cutoff, because beyond 75, the capacity for regeneration drastically reduces. But having said that, it again depends on the individual. We need to do all the necessary blood investigations, look into how mobile they are, what their lifestyle is, and all of that. I think that should be a guiding factor for us rather than take a number and cut off there. But usually we've seen that it's the number is between 70 to 75. So on those age groups, again, that's also an area where, as far as possible, we try to avoid surgery. If only if we know that the patient will do well, and if we intervene, then only we will intervene. Also, what is an issue is the bone quality is very bad for such
Yes.
patients. They will usually have some amount of osteopenia or osteoporosis in other parts. If you're doing on the spine, then osteoporosis becomes an issue. On the skull, also osteopenia can happen. The suture lines are far less, more prominent. So it's hard to actually intervene, but there are some surgeries that can be done regardless of the age. I've operated on a patient who was 100 years old. So he had something called a chronic subdural hematoma. So a chronic subdural hematoma happens so as we grow older, what happens is the brain shrinks. So let's say this is the skull. So when you're young, the skull and the brain are like this. So as we grow older, the brain is going to shrink like this, but the skull won't shrink. The skull will stay like this. So there is a gap between the skull and the bone. So that's a potential space where fluid can go and sit. So in older age people, it can be a trivial thing. Like when you're walking, you could have just bumped into the wall, or you could have hit something, or you can have a sudden jolt of the head. So there are some blood
Like the
vessels that
counter
run
group injuries we have, where there is already impact on other side, but the vector is on the other side, and
on
it
the other
continues
side. So
always.
that also can cause. So all of these scenarios, that those blood vessels in that potential space, they rupture and slowly the blood will start sitting. So in that case, we just do something called a burr hole. So we place two small holes on two sides of the head, and once that small hole is put, we can clean off all the blood from there. So we recently had a 100-year-old patient who came in with this problem. He had presented to the ER. We had operated, and within 2 days he was standing upright and he was able to walk and he was doing other things. But the main thing you have to remember is he didn't have other issues. So as when you're treating with geriatric patients,
Comorbidities.
it's
Yes.
not the primary problem. That's the thing. They may have uncontrolled diabetes, they may have other cardiac diseases, they may be immobile, they may have better bed sores already. So you need to treat the patient as a whole, look at every system of his body, and then I think that's how we proceed in such cases. So
So
yeah.
in
So
geriatric patients, if you talk about, our treatment also differs because their chances of being already edentulous, because they do not have dentate segment, and already the blood supply to the periosteum is so compromised as such that the resorption has already happened in this. There is no viable amount of bone height or bone girth that we can get. And not just the bone height of this, even the bone quality again, because it's a D4 or D3 type of bone. The bone density is far lesser as compared to an adult patient. In those kind of patients, there always be chances of multiple fracture segments. Maybe even if it is not visible on the radiograph in a span of 2 weeks, it will always be visible later on. But there will
mm,
be chances for those kind of patients to have multiple fracture segments. And not just that fracture segments, they will also have long bone fractures of the other side, like
right.
the thighs or the legs, because usually they do not just there's a more history of slip and fall from those situations. So they would be standing somewhere on a height and they would have fallen down somewhere. So in those cases of chances of long bone fractures is very evident in this. Again, the treatment changes per se, because we cannot always do aggressive surgeries in those case scenarios. We can give a primary surgical intervention, but the chances of malunion and non-union happening in the situation is extremely wide, sir, because they already have no potential for bone regeneration per se, because the bone quality and bone capacity again has reached to a certain limit. And then even after we do an intervention, there's a higher chances of how the fracture segments will heal, because according to that fracture segment healing, none of us have a control over that segment healing. Even after proper care and management and a proper reduction and fixation, the fracture segment healing is a lot of times more genetic as compared to what we give. In scenarios such as comorbidities associated, such as osteoporosis and all, where we do not have any interventions in such cases of fracture, because they already have brittle bones and they will always fracture very frequently as compared. Even if they are standing and they fall from some height, they would have more fractures or more prone to fractures compared to this. So in situations like that, where you come across patients having comorbidities as such, how do you deal with those situations? Because it changes the game, it changes the treatment all of it together. It changes the prognosis, it changes the intervention as such
So I
from
think
both point
that's
of
where
sides.
patient selection plays a very important role. You need to operate on the patients who you think will do well. When you think they are not going to do well, you should tell them that this is, may not work. This is what's going to happen. So are you still okay with doing this? So I think that's the only thing we can do. We'll have to treat their comorbids. Only if they're stable for surgery, then go ahead and operate. If you think that they're not going to do well, they're unstable. In such cases, unless it's a life-saving procedure or a life-saving emergency, I think we should postpone the surgery unless until they become more stable, or not offer surgical intervention, offer a conservative treatment in such patients who are having such bad comorbidities, like you said.
So again, and a
Definitely.
physician plays a role in this where he has to
Definitely.
intervene, give a clearance from his side, because a lot of
Correct.
times patients having HbA1c which is uncontrollable diabetic patients, patients having hypertension, and even if you have patients who undergo maybe intraoperatively also, so a lot of times there's a scenario where we have this trigeminal reflex which happens because of the vagus nerve which tends to be stimulated whenever we are trying to fix the zygomatic arch fractures or the zygoma fractures. The patient develops severe bradycardia at the
Yeah,
time of
that's
surgery.
the trigeminal nerve, not the vagus. It's the
The
trigeminal nerve which gets stimulated. So it's called a trigeminocardiac
reflex.
reflex. So
I think you
because
would have
you're,
also
yeah.
encountered this.
So those cases usually they settle on their own. You don't need to do anything. It is self-limiting. You just have to change the position of the patient and it will limit by itself. But if it doesn't go down despite you waiting for 5 minutes, then you have to pour some cold saline over that area where you're operating, and that helps numb that reflex. It's not a scary reflex. It doesn't cause any a thing like a loss of life or a cardiac attack as such because of this. Because it's just a benign reflex that's happening, and it'll self-limit and it'll settle down by itself.
Okay.
So I think that you don't need to worry so much about.
I think so.
Well,
We have covered a lot of scenarios.
yeah,
Thank you so much for the session. I think it was a very
sure.
wonderful and helpful session for a lot of people who are watching.
Yeah,
Yeah.
definitely. It was glad to see you and to also know about the maxillofacial side of things
Yeah.
and what
So
kind of
definitely it was.
interventions you do. I think definitely the target audience would have had a great learning from this session. So
The
thank you for
awareness
having
about
me.
the awareness about trauma as such is not very evident in rural parts of India, sir. We have patients who have not wanted surgical intervention even after telling them that this could be a life-threatening situation, and they end up getting involved in life-threatening situations, post-operative surgeries and infections, which is very cumbersome and uncontrollable to them.
Yeah.
And then all the times a lot of blame is put upon the healthcare system that we work upon, that the doctor was not doing his job perfectly or his work nicely, which apparently is not always a fault that we would have to take.
Right. So I think more awareness like this definitely helps in getting people on board, making them understand what is actually happening, why we're doing what we're doing. I think that's a very important part of the thing.
And
So
also the immediate intervention that is required a lot of times. Rather than waiting for a point of time to be stabilized in this is okay, but after a certain period of time where patient is coming about a span of 1 to 2 months for a surgical intervention now, which is very, it's always going to be hectic, so for us also to even give him a proper fixation per se, because the chances are going to be high of a failed treatment as compared to the a proper treatment even after a proper surgical intervention as such.
yeah, I think that's why I think we need to do things like this so
Yeah,
that the community learns the
the
importance of
awareness towards
what we're
trauma
doing,
and its
and
management.
also tell them that see there is hope. It's not that if you have an accident you're definitely going to die. It's not that if you do a brain surgery you're definitely going to die.
People
It's
are
not
very
that if you
adamant
do
towards brain
face
surgery.
surgery your face is going to get ruined. So I think that stigma will be cut off if we do more awareness things like this. I think definitely people would have benefited from this session.
Yeah,
So it was nice to collaborate like this.
yeah,
Looking forward to more future collaborations like this. Take care.
yeah. Thank you, sir. The pleasure was all mine. It was a very interactive session. Thank you for
Thank you.
giving me your time. I know you have just come from rounds, so apparently you will have still more calls to give. But it was a Sunday well spent. So thank you so much for all the information and all the sessions that we had,
Sure.
the session we had, sir.
Sure.
Yes,
Thank you for
thank you.
having me.
Yeah,
All the
thank you,
best.
sir.
See
Thank you,
you.
Dr. Chan. Thank you.